this pre-test. Good afternoon, friends. Welcome to the 10th session of the NHSRC DSP RUD series for implementation of standard treatment guidelines. We will be starting soon. Meanwhile, you can start attempting pre-test. The link for the session I'm again uh, putting in the chat box. I hope you are able to open this. It's there. Pre-test link is there in the chat box.
Uh, Ma'am, advisor sir has arrived. Can we
Okay.
start?
Abhi, they have just started doing this pre-test, no?
Okay.
I've asked Dr. Ekta to come at 3:15 now.
Okay.
Ranjit, could you speak to Dr. Neeraj Gupta?
Yes, ma'am. I'll talk. Yeah. Yes.
Ekta is also here. You can call advisor, sir.
Yeah, ma'am, we can start if sir is there.
हाँ, he has also come. रंजीत आप बुला लो उनको भी.
He is coming in 5 minutes, ma'am.
Okay, okay.
सर आ रहे हैं सर.
Good afternoon, friends. Welcome to the 10th session of the third series on implementation of standard treatment guidelines. We'll be starting soon. Meanwhile, I've put the pre-test link in the chat box. You can start attempting that. We have three esteemed faculty members for taking these sessions today, and the topics are also very, very relevant. We'll be in the first half, we will be uh, discussing about the diagnosis of viral hepatitis, and then followed by management of viral hepatitis, and then session would be on neonatal jaundice. We'll be starting very soon. Meanwhile, you can complete the pre-test. I've got only 26 responses so far, whereas I see in the room there are more than 140 people. I hope there is no problem in opening the form. You are about to submit the.
सर आएंगे तब वीडियो ऑन कर दीजिएगा और सर को फोकस करिए।
Pretest link is there in the chat box. Please start doing it.
Ma'am, we'll start at 3:30.
He said he's coming.
Okay.
There are-
Yes, ma'am. Sir has come.
अच्छा ठीक है.
Just wait.
Good afternoon, everyone, and welcome to the program. I'm Dr. Rajiv Patni. So nice to see you, ma'am.
Yeah, same here. Welcome.
Thank you, ma'am, and welcome back, I should say. Uh, uh, for those who have just joined in, Dr. Sangeeta Sharma is the life behind this entire exercise, this standard treatment guidelines webinar. So we are very happy to have you back. We missed you last time when we were discussing cancer. Uh, and I welcome our panelists, Dr. Ekta Gupta. I can see you there. Welcome, Dr. Ekta. I understand the other panelists also joined. Yeah, they're joining. Dr. Ankur Jindal and Dr. Neeraj Gupta. This time we have picked up a very interesting subject where the burden of disease is quite high. There is extensive morbidity. There is and leading to mortality as well. And a third thing we have picked up is neonatal jaundice, which has morbidity, but it comes with a lot of anxiety. There is a newborn in the family, and one day out of the hospital, the next day the newborn is back in the hospital for treatment. So there are anxieties, there are apprehensions, and there are a lot of misgivings and misunderstandings there. So that's the set of topics we are going to talk about. Just very briefly about what this webinar series is. This is the third iteration of our very popular series. We've had more than 12,000 people, healthcare professionals, who have benefited from this already. For those who are new, there are people who already know the protocols, but for those who are new, everyone who finishes the pre-test and the post-test will get a digital certificate on their email. So please make sure that you're given the correct email. If you have qualified after the post-test, the digital certificate will be emailed to you after we have verified the result. We have already issued out 3,820 certificates. So it means that you will definitely get your certificate if you have qualified through this. About the subject, hepatitis, we all know what is hepatitis. It's the inflammation of the liver. You will hear all details about this thing from the two speakers who are going to talk about hepatitis. But the concern is the loss of work days, that's at the lower end of the spectrum, and leading to cirrhosis and hepatocellular carcinoma, that's the other end. So it is from the mild severity to a chronicity to terminal events. Hepatitis straddles the entire spectrum. We will learn about this thing in more detail. WHO has identified this as a disease of concern, and we in India also we have a hepatitis national viral hepatitis control program, which was launched in 2018 under the NHM. This is, and we are also targeting elimination of hepatitis C by 2030 under the same program. There are different modes of transmission, which will be covered in detail once again. There are food and waterborne aspects, and there are the parental aspects, contact aspects, which will be covered in detail by our two speakers. We will be talking about a diagnosis and management. The two speakers will be covering this in detail. And I'm really looking forward to hearing them speak because they are experts in their field. And I'll be joining the audience in enriching myself through these deliberations. This will be followed by a talk on management of neonatal jaundice, for which we have Dr. Neeraj Gupta, professor and head of the Department of Neonatology from AIIMS, Jodhpur. This is a disease which I shouldn't call it a disease, it's a condition which comes with a lot of anxiety, as I said in the very beginning. And Dr. Neeraj Gupta will help us learn the strategies and how to allay these apprehensions in the new mother and the family about this aspect. So, with this, I hand it over to Dr. Sangeeta Sharma, ma'am. Ma'am, please take it forward, and we're looking forward to this session.
Thank you, Dr. Patni, and welcome to NHSRC. We are looking forward to a new, era of quality and patient safety. I hope under your leadership it reaches another milestone. And thank you for supporting this series as well. And as you said, this is one of the very, flagship program where we try to reach out to as many people across India. So the novelty of this program is that we, this has become a national level initiative to implement standard treatment guideline, and always our endeavor had been to uh, take up the topic and take up issues which lead to inappropriate clinical variation, introduce standard treatment guidelines for their management so that these inappropriate variations which compromise the quality of care are minimized or eliminated from clinical practice. And today I have a pleasure of introducing Dr. Ekta Gupta. She's professor and head Department of Virology, Clinical Virology at Institute of Liver and Biliary Sciences in New Delhi. And she is a nodal officer for WHO Collaborative Center on Viral Hepatitis. She has more than 28 years of experience in this area and in transplant virology, and she's been very academically active, has more than 150 scientific publications in the journals, and she's author of 11 chapters in the books. And she's currently very actively involved in the research both at the national and international level. And she is one of the task TRG member in National Viral Hepatitis Control Program, coordinator for microbiology training at NBEMS, and she during COVID time she was heading this COVID-19 testing laboratory and genome sequencing lab for Delhi State. She's been associated with DSPRD for many years, and for us, we introduced this diagnostic stewardship program, and under that diagnostic stewardship program she was looking after antiviral stewardship module, which was really very well taken up by the participants, because this is one area most of us get overwhelmed because of the different types of tests, their interpretations, and sometimes when we lack this diagnostic facilities, again we get overwhelmed. How do we manage these patients? Over to you, Dr. Ekta Gupta, for diagnostics of viral hepatitis.
Yeah, thank you so much, ma'am. It's been an honor, and thank you once again for giving me this opportunity. Thank you, Dr. Rajiv Patani and Dr. Ranjit from NHSRC. And I'll share my screen. Can you all see my slide?
This is your email slide, Ekta.
Now can you see, ma'am?
Do you have your PowerPoint open? We can see that email here.
मैं शेयर करता हूँ क्या है आपके पास? हाँ भेजिए.
Ranjit, do you have her presentation?
Yes, ma'am. I have the presentation.
Acha, I think now no, Ekta, we are seeing your email only. You have to open the window, PowerPoint window. If there is any issue, Ranjit can share from their end.
No, can you see now?
It's the same slide, email that we see. Shall I click a photo for you? That will help you.
No.
Sending you on the WhatsApp.
No, I got it. I'm trying to just change.
to MD का है. यहाँ से तो शेयर है. Inbox कीजिए.
Ma'am, you can, if we can share.
Ranjit, can you share from your end?
Okay, ma'am. I am sharing.
Okay.
No, I'll let me share. I'm trying.
कहाँ डिफिकल्टी आ रही है? शेयर करोगे ना, आपका पावर पॉइंट खुला हुआ है जो स्लाइड प्रेजेंटेशन है?
हाँ, पावर पॉइंट खुला हुआ है मेरा. अब दिख रहा है? मैम, अब दिख रही है मेरी स्लाइड्स?
नहीं मैम.
नहीं, अभी नहीं दिख रहा है. रंजीत कर देते हैं, नो प्रॉब्लम. आई थिंक थोड़ा सा आपको इनकन्वीनियंस होगा, बट आई थिंक ही कैन डू इट.
यस मैम. जस्ट नेक्स्ट करनी है, मैं चेंज कर दूंगा स्लाइड.
अब दिख रहा है मैम? अच्छा ठीक है, आपने अब दिख रहा है मेरी तरफ से?
नहीं, अभी एक ही शेयर कर पाएंगे, या तो रंजीत कर पाएगा या आपका होगा.
ओके
मैम, मैंने शेयर कर दिया है मैम.
Okay, no problem. Yeah, we'll start. So very good, ma'am. Now everybody can see and hear me also. You can hear me?
Yes, ma'am.
Yes.
Okay,
Carry on.
Okay. So very good. Okay, when I'll start saying next, then you please move on the slides. So I'm sorry for the last minute glitch. Okay, so the topic which was given to me is the lab diagnosis of viral hepatitis. Next slide. Yeah, so as you can see that the word hepatitis involves hepata and itis, that means liver plus inflammation. So all the causes which causes inflammation to the liver are known as hepatitis. Viruses, they are the predominant cause to cause inflammation to the liver. Out of them, hepatotropic viruses, those which have a tropism to liver, and we classify them with the letters A, B, C, D, and E. They are the predominant cause of causing inflammation, and that is why viral hepatitis. Apart from it, there are other viruses which are known as non-hepatotropic, which can also cause inflammation to the liver. These viruses are like dengue, influenza, COVID, CMV, in which sometimes the liver function test is also raised. There are, apart from these viruses, you have other causes like alcohol, drug, few other infections like parasites, which can cause inflammation to the liver. Next slide. Next. So when we look at liver, you have this healthy liver. Then there are stages. When the inflammation occurs, sets in, it can lead to fibrosis. The last stage of fibrosis, cirrhosis, and ultimately liver failure and HCC. Now, looking at the different liver function test, what defines what? There are certain markers which tell you about the damage to the hepatocytes, which we normally see as LFT, like ALT, AST, and they are the markers which tell you about the damage to the liver. When there is obstruction to the biliary tract, and there are markers like ALP and GGT. So, and then there are certain markers by which the synthetic function of the liver is lost, which are in the form of the albumin, and tumor markers is AFP. Next slide. Next slide. So broadly, when we look at the functions of the liver, we classify the markers in terms of bilirubin, which are the excretory markers, ALT/AST, which tell you about the liver cell damage, alkaline phosphatase, GGT, biliary obstruction, and functions of the liver in terms of albumin and prothrombin time. Next slide. Now coming on to the next slide, the topic, that is hepatitis viruses. So as I told you, the hepatotropic viruses are 5 in nature. We call them A, B, C, D, and E. Like remembering is very, very easy when we look at 5 fingers on our hand. All of them are RNA virus, hepatitis, except for hepatitis B and D. B, which is a DNA virus. The mode of transmission is very, very important. And in terms of the jaundice they can cause, A and E, they are the foodborne. So the mode of transmission is through contaminated food and water, while B, C, and D, they are through the periantral route, means the sexual transmission, bloodborne, or the perinatal transmission is very, very important. Chronic infection and ability to cause HCC is important. So the chronic infection is associated with hepatitis B and hepatitis C, and D, which is a defective virus, also can cause chronic infection. A and E are mostly causing the acute jaundice or acute hepatitis. Treatment is available for B and for C, D, of course, but A and E, we do not have treatment, so you have only prevention as the method by preventing occurrence to the jaundice caused by them. Next slide. Yeah. So the global concern is there towards viral hepatitis. As you can see, this is the data from WHO. And on this, the mortality by tuberculosis, HIV, and malaria all is slightly declining, the number of deaths. However, by chronic hepatitis B and C, these deaths are rising. Now, because of this, the SDG has laid down global goals for each country to achieve by the year 2030. Next slide. In our country also, we are moving towards control, and in 2018, we have launched National Viral Hepatitis Control Program. This is controlled by NCDC, and in order to control it, they have made these state hepatitis control program and national at each state, more than 160 sites. They have different states and districts and sub-district level. This program has started functioning. Right now, it is looking towards B and C, diagnosis and management. Also encompasses A and E, diagnosis and control of cases. Next slide. What we have seen in controlling viral hepatitis is lack of diagnosis is a major gap. As you can see in these publications, 2019 and 20, there are so many patients who are infected all around the world, including India, for hepatitis B surface antigen positive or anti-HCV positive, but look at the percentage who've been diagnosed and put on treatment. So we really need to uptake the task of diagnosis of viral hepatitis in our country. Next slide. We can actually increase the diagnosis by increasing the knowledge and awareness that we are doing among all the healthcare workers, especially doctors, nurses, paramedicals. and we should start decentralized approach, means moving the care for hepatitis, management for hepatitis from tertiary care centers to small peripheral health sectors and PHCs and sub-district level at these centers. We should move towards providing affordable, accurate, and easy to perform diagnostic tests, so that you should have same day test and report, and you can refer the patient to treatment and management. Starting more molecular testing lab and doing a lab integration and networking as far as viral hepatitis is concerned. Next slide. So right now, whom are we testing for viral hepatitis? We are looking for hepatitis B and C whenever we screen donated blood and organ donors. Anybody who walks in with abnormal liver function test, which I have told you, we evaluate them for viral hepatitis. If there is a healthcare worker who happens to have a needle stick injury, we evaluate for B and C. Mothers during their antenatal checkup are routinely screened for hepatitis B, but not for C. And under NVHCP, which I have already told you, from 2018 onwards, there are many treatment and testing centers which have been made across several states, and they are actively involved in looking for patients who are coming up to these centers with acute jaundice or chronic jaundice. And the high-risk populations like HIV, hemodialysis patients, we are routinely screening for hepatitis B and C. Next slide. Next. Yeah. So talking about hepatitis B virus, next. It is a double-stranded DNA virus, and one strand of it is partially double-stranded. The important markers which we test in the blood are the antigens which it has on its surface. So hepatitis B surface antigen. Core antigen is not there on the surface, and it remains inside the liver only whenever the virus is there. It is never expressed into the blood. And there is an E envelope antigen. So there are two important antigens, surface and envelope antigens. Against these surface antigens, you form antibodies, anti-HBs and anti-HB core antibodies are there in the blood, which can be IgM and IgG type, and then anti-HBe. So these are important markers. And then the nucleic acid, that is HBV DNA. Next slide. How do we get hepatitis B infection? As I showed you, that it is mostly perinatal or blood transfusion or sexual transmission. Now, if an adult acquires this infection, 90% of the chance the body's immunity is able to clear the virus. So you will only present with acute short duration infection, means the virus gets cleared within 6 months, mostly asymptomatic, might present as acute viral hepatitis, or less than 1% may land up with acute liver failure. But if the transmission of the virus is mother to child at the time of birth, then 90% chances are that the person will have, or the child will land up into chronic infection, means persistence of hepatitis B surface antigen beyond 6 months. So there'll be chronic hepatitis B. Then it will cause damage to the liver. So it will present as cirrhosis, which is initially compensated and then get decompensated. So what is the most important step to prevent hepatitis B is at birth immunization for hepatitis B vaccine, because 90% time from mother to child, it will land up into a chronic infection. Next slide. Next. So acute infection, which when the body clears, the first marker to appear, as you can see on this graph, is hepatitis B surface antigen. This is immediately followed by antibody response to the core antigen, which is initially IgM type. Then it becomes IgG, which we call it as total anti-HBC. Once the hepatitis B surface antigen is cleared, antibody to hepatitis B surface antigen is formed, which is seen as anti-HBs. At this stage, I want to tell you that during the acute infection, the markers may disappear from the blood. But once the virus is encountered, it always remains lifelong inside the hepatocyte. So acute hepatitis B, we define as clearing of these markers from the blood within 6 months. However, the virus persists inside the liver. Chronic infection is when all these markers, especially hepatitis B surface antigen, is persist beyond 6 months. So surface antigen will always remain. IgM might occur, but it is the core total antibody which tells you more about, or IgG type of HBC antibody, about the chronic infection. Next slide. Next. Now, there is an interesting story that when the virus enters the body's immune response there is a battle going on between the virus and the body's immune response. And depending upon this, the phases of hepatitis B are described. Next slide. We describe hepatitis or chronic hepatitis B into 4 phases. So once the virus enters, the body tolerates. So the first phase is immune tolerant. What all you see here, all the viral markers are very, very high. So surface antigen is present, E antigen is present, IgM core is also will be present, or sometimes even HBC total is also present. But the liver function tests are normal, and that is why we are tolerating it. So this is known as E antigen positive chronic infection. Now, once the immune active phase starts, the surface antigen, E antigen, anti-HBC, all are positive. DNA is also high. Apart from it, the ALT becomes abnormal. So liver function test gets deranged. Person will present as jaundice. And this is known as immune active hepatitis. That is the second phase. Now, once the immune control sets in, you have the clearance of these markers. So surface antigen might persist, but antibody response in the form of anti-HBe, anti-HB core all start forming. Liver function gets normalized. And so this is known as immune control or inactive carrier phase. In this phase, the patient may survive for many, many years. So the first phase is usually seen when the person is very young, and then there is immune active. Slightly after a decade of it, you will see this. And then immune control, the patient may persist for many, many years. And then there is a fourth phase, which is known as, again, immune escape or reactivation, when once again the immune control is lost and all the hepatitis B markers are raised. There can be a time that total resolution of hepatitis B by the body can occur, and then all the viral markers becomes negative, liver function is normal, and that means a resolved phase, or sometimes we also call it as occult hepatitis B infection. Next slide. Next. Next slide. I can't see the slide moving.
It's moving now.
Okay. Okay. So previous slide. I think you have moved a lot of them. Previous. Yes. Yeah. So when we talk about the various markers, hepatitis B surface antigen is a very important marker in diagnosis of hepatitis, because that is the first marker to appear. It tells you about active infection, and acute and chronic infection is depending upon its presence. So it is present beyond 6 months, it's chronic, disappears from the blood, it's acute infection. It also mounts a very good immune response, which are known as antibody to hepatitis B surface antigen. These are neutralizing antibody, and they give you protection from so their presence means a person has got protection. Now, this can also be seen following a hepatitis B vaccination, because in the vaccination we use recombinant antigen, not the complete, but a part of an antigen. So only anti-HBs response is there, which is protective. Next slide. Now, anti-HBs, measuring the level of anti-HBs will tell you about the immunity or protective level following an hepatitis B vaccination. Ideally, the level should be tested after 2 months, that is 8 weeks, and there should be done only when complete all 3 doses of the vaccines are given. We have 3 doses, 0, 1, 6, and once the series is completed, then only the anti-HBs titer should be checked. Now, anti-HBs titer can come even after inadequate doses, but then it will not give you a good protection. So it should be checked only once your complete series and the correct dosage has been given. More than 10 is considered. Can you hear me?
Yes.
Yeah. So more than 10 is considered as protective. Next slide. There are a few markers which are new markers of hepatitis B. HbS quantitation is one of them, I want to tell you, because once you put the patient on treatment, the DNA becomes negative, and surface antigen usually does not get converted into seroconversion is not there. So you can actually measure the surface antigen and can look for the and monitor the response of the patient, or is he moving towards the seroconversion or not. This is a newer test which has come up, and few labs are only doing it. Next slide. So core antigen and antibody are another important markers in hepatitis B. As I said, core antigen is never seen inside the blood, but it is the antibody response to it by which we actually look for an exposure. Now, there are two types of core antigen antibody response: IgM type, which appears during the acute phase, and IgG type. And IgG type and IgM combined is known as total core antibody. Most of the labs are actually looking for anti-HBC core total because it is difficult to differentiate between them. And anti-HBC core total level actually tells you that the person, this occurs only after natural exposure to the virus. So anti-HBS may come after vaccination, but if a person has got antibody to a HBC, that means that there is an exposure to the virus that has happened. That only will come once person is exposed to the virus. Next slide. E and antigen and antibody to E are also important. E antigen is produced when the virus is actually replicative. So that gives you a hint that there is a high viral load. Antibody to it is developed, which tells you that the body is mounting the good immune response. So sometimes clinicians also use the conversion from E antigen positivity to anti-HBE formation as a good marker and a marker to treatment response. Next slide. So interpretation of various markers, as I've told you, if the HBS, core total antibody, and anti-HBS, these are important markers by which you can look for an infection. So if all are negative, means never exposed but not vaccinated also. If you have core total antibody and anti-HBS, means there is immunity has there following a natural exposure. If only anti-HBS is there, means person has got an immune response following a hepatitis B vaccination. If IgM type of anti-HBCs are seen, means there is acute hepatitis B infection. If HBsAg along with total anti-core antibodies are seen, means there is chronic infection. And sometimes a very peculiar only core total antibody response is seen, which can be seen during the recovery from following an acute infection, or sometimes it can be false positive. But core total testing also is a very, very important marker which can tell you about exposure to hepatitis B. Recently, CDC has incorporated that apart from HBsAg, if you are screening a person for exposure, do a core total antibody test also. That also can give you a lot about whether there is exposure has occurred or not occurred. Next slide. So this, I think Dr. Ankul will take. I'll just tell you that important markers when we look for management are hepatitis B surface antigen and HBV DNA, based on which you can put a patient on treatment. Next slide. Now, coming to another important virus, that is hepatitis C virus. Next. It is a simpler virus as compared to hepatitis B. It is an RNA virus, and there are only two important markers. So once the infection occurs, against these envelope and core protein, the antibody response occurs, but these antibodies are not neutralizing. These antibodies rather tell you about exposure to infection, means the person is infected. And then we do an HCV RNA if we want to see for an active ongoing infection. Next slide. Hepatitis C can also be acute in 20 to 30% when there is exposure has occurred, which we'll see by antibody as well as HCV RNA. And RNA on its own gets negative within 6 months or 3 months. So this is known as acute HCV, which is naturally resolved. But 70 to 80% chances the body cannot take care of this virus on its own, and patient will land up into chronic HCV infection, which is seen by presence of HCV antibodies as well as HCV RNA. Next slide. So in HCV infection, we have only two important markers: antibody to HCV and HCV RNA. There is another marker which has recently come up as HCV antigen, but there are very few labs which have got, and it's not there available in most of the states and in many of the countries, which can also be used for checking for an ongoing infection. Next slide. So HCV management is dependent on looking for antibody to HCV and then confirming an active infection of RNA presence and then putting the patient on treatment. Next slide. Once you have put the patient on treatment, you give the treatment, wait for 12 weeks, and then you look for another HCV RNA negativity. This we call as sustained virological response at 12 weeks. And if the SVR12 means negativity of RNA is seen 12 weeks after stoppage of treatment, that means virus is cleared from the blood, and we call it an HCV cure. So unlike hepatitis B, hepatitis C can be actually cured because this does not go and forms a integration into an hepatocyte. So it gets cleared. Unlike hepatitis B and HIV, where the virus persists inside the host for lifelong. And once you put a patient on treatment, there is no need to do any on-treatment monitoring by doing an RNA repeatedly. These days, pan-genotypic drugs are available, so genotyping or drug resistance testing is also not routinely recommended. They are only done in few treatment failure cases. Next slide. Another hepatitis virus is hepatitis E virus infection. Next slide. It causes mostly acute sporadic viral hepatitis in adults, and of late there is a declining incidence is seen in adults also. However, the mode of transmission is through fecal-oral, as I told you, through contaminated food and water. There are several genotypes of the virus. The human genotypes exclusively cause jaundice and acute viral hepatitis, which gets controlled. However, there are few genotypes which are zoonotic, like 3 and 4, and in immunosuppressed individual in Western world, they have been known to cause chronic hepatitis E infection. Next slide. Now, looking at the lab diagnosis, the first marker to appear is the IgM type of antibodies to hepatitis E virus. Although the virus itself, that is in the form of HEV RNA, can be seen in the blood, but it is there for very short duration. HEV virus in the feces is excreted, but then it becomes non-specific. Sometimes when the clearance of the virus is also achieved, the virus can be shed in the stool. So the important diagnostic marker which matches with derangement or acute jaundice is IgM antibody response to HEV. So acute viral hepatitis by HEV is usually or routinely diagnosed by looking for IgM type of antibodies to the hepatitis E virus, and the various ELISAs are available. Now, difference between the HEV in which normally causes the acute self-limiting hepatitis and chronic is that the human genotypes, genotype 1 and 2, can cause this self-limiting. You do not require treatment, and diagnosis is by HEV IgM. But few Western world, we have not seen it in India. It can cause persistent infection, and then it is known as chronic HEV infection, and that requires treatment, and diagnosis is by detection of HEV RNA doing a PCR. Next slide. However, next slide. We have also seen that, and other centers also, that we do not see chronic HEV infection. Right now, we are not seeing in India. Next slide. Next. Hepatitis A virus, next, is another virus. It causes acute viral hepatitis in children. less than 6 years, it may present as asymptomatic and go and cause spontaneous recovery. However, few, it may land up into acute symptomatic hepatitis, may land up into acute liver failure, requiring even liver transplantation and other extrahepatic complications. Next slide. Just like hepatitis E, the typical viral marker is IgM type of antibody response, which peaks with the clinical onset of the disease, the peak of ALT derangement, and that's an excellent marker to diagnose hepatitis A infection by doing IgM type of HAV testing. Next slide. Recently, we have been seeing slight changing epidemiology. We are seeing more of hepatitis A in young adults and adolescents, and who are landing up and causing liver failure. And we've published this paper, and the immunization or the vaccination practices, especially in the pediatric age group, should be encouraged if they are not immune, that is by looking at HAV IgG by the age should be inculcated, or those who are suffering from chronic diseases, they should be encouraged to take up hepatitis A vaccination, because earlier it was thought that by the age of 10 years 95% of the population is protected, but because of the improved water condition and sanitation prevailing, this protection or the presence of HAV IgG has been seen to be declining, and that is why you're seeing more of slightly adult and adolescent age group coming up with hepatitis A infection, which may cause liver failure and severe form of hepatitis A in them. Next slide. Now, the last virus is the Delta virus, which is also known as defective virus. It cannot cause infection on its own. It requires hepatitis B surface antigen to cause infection. It can cause infection in two forms, means simultaneous co-infection, which is mostly acute, but gets recovered, but can cause fulminancy or liver failure, or there is Delta virus superinfection on a chronic infection, and that will lead to more severe disease. Next slide. Next slide. In India, earlier the incidence of hepatitis Delta virus was very high, but of late we have not seen the incidence is less than 2% or 3%, and so it is also not included. It's not looking like a major concern in our country. Next slide. Next. So, however, globally, the concern has been raised for hepatitis Delta virus, and various guidelines and recommendations are saying that those who are hepatitis B infected, they should also be screened for the Delta virus, but we are not seeing many cases of this Delta virus infection in our country. Next slide. Just a word about, there are lots of testing methodologies. You have, you normally test for viral hepatitis by rapid card tests, which are card-based tests. You can do ELISAs, and then you confirm DNA and RNA by doing the nucleic acid detection tests, which are PCRs assay. Next slide. Next. And there are lots of near point of care molecular testing devices, means these are small devices which can do PCR, but they are handheld, like CBNAT instruments or TrueNAT instruments, which should be encouraged, and they can easily do viral hepatitis testing for RNA and DNA. Next slide. So sampling techniques have also improved. Rather than collecting whole blood, we can also look for these viral hepatitis marker in dried blood spots. Oral fluid test for hepatitis C has been launched by WHO, but not available in our country. Next. This is the common testing algorithm which is there for a jaundice patient or acute hepatitis B, acute viral hepatitis, where you have to suspect all the four, that is A, E, B, and C. And as I said, for A and E, IgM, and B and C, surface antigen IgM, and C is only antibody. And then you can send them for, refer them for care. Next slide. For chronic viral hepatitis, means those who are not presenting with jaundice, we just look for hepatitis B and C. Again, surface antigen for B and antibody to HCV for diagnosing viral hepatitis in chronic cases of chronic patients. So I thank you all. I hope these markers are clear. Thank you.
Thank you, Ekta, for giving us elaborate diagnostics. And truly, even I also get overwhelmed by so many tests, but I hope some of the take-home messages are clear. The minimum, I think can you just summarize once again the minimum tests that are, because we have participants from primary care level, secondary care level, who may not have these kind of diagnostic facilities available. So can you summarize for them that these are the minimum possible
So,
and the timing of getting these tests done?
yeah. So for as I summarize in the end, if the patient presents with acute jaundice, acute viral hepatitis, deranged liver function test, in that case, B and C, A and E, these four markers, A and E, IgM type of antibody, A and E you should test for, and for B and for B, hepatitis B surface antigen, and core IgM for hepatitis B, and for C, antibody to C. So these five markers, that is IgM A, IgM E, surface antigen of B, core IgM of B, and antibody to C if you are having acute jaundice case. Now, if you have chronic case where is a liver function test is deranged, there is no acute incidence. In that case, the screening is required only for B and C. B by hepatitis B surface antigen, and C by anti-HB antibody to hepatitis C, which should be done.
Thank you. I hope it is clear. If possible, can you for question and answer session? I don't know whether you will be available, or can we take up one or two questions now quickly?
Yes, ma'am, sure.
You can write the question in the chat box. For those who are asking for the slides, the entire session would be available on YouTube. There is a YouTube channel of NHSRC, QPS channel of NHSRC. You can view all of these sessions, even the previous ones on this channel. I think there are no questions. She has already repeated acute viral investigations.
Yeah. So actually, I have said from the lab point of view that for acute jaundice, we do hepatitis B surface antigen, hepatitis B core IgM, antibody to HCV, A IgM, and E IgM. But I think management, Dr. Ankur will say, depends upon the algorithm I have said. For hepatitis B surface antigen, DNA needs to be done, fibrosis, which I think Dr. Ankur is here, he will share. For anti-HCV, presence of an RNA is required for management. But for diagnosis, it is A IgM, E IgM, hepatitis B surface antigen, and antibody to HCV.
And there is one question about if baby is tested positive for HBsAg, do we vaccinate the child?
Yes, I think the neonatal management will be shared later on. That is why I did not tell about the perinatal or neonatal diagnosis. HBsAg can be there in the, so if there is a hepatitis B positive mother, is a high risk mother who has delivered a baby, you give both the immunization and immunoglobulin and management, which the clinician would tell you. And we check for the confirmation of infection in the child is done we wait for 3 to 4 months only. It is not done immediately after that. Then you look for the surface antigen positivity. In case of an HCV transmission, we look for antibody to HCV only after 18 months of the age of the not immediately after birth. But because the virus, the DNA, the antibody, they can also be falsely transmitted from mother to child for few months inside the neonate. So we do not do immediately the testing.
There's one more question. Some patients have raised serum bilirubin levels, although HBsAg and anti-HBC is normal. What is the reason?
Initially I showed the slide that what are the liver function tests, and bilirubin tells you about the conjugation defect. So apart from viruses, there are non-hepatotropic viruses, then there are other causes by which the liver function test will be abnormal. So there are so many. So it is not, so the talk was only on viral hepatitis. So it's not necessary that only viruses can cause abnormal liver function test.
Thank you, Ekta, for taking up this question. Now we can move to the next. Thank you very much for sparing time. Now we invite Dr. Atul, Dr. Ankur Jindal.
Yes, good morning. Am I audible, ma'am?
Yes, yes. Good afternoon. Very welcome to the this third series of DSPRUD NHSRC series for implementation of SDGs. We are running this series for last 3 consecutive years, and today is the 10th session, and we are very happy to have you with us. I have the honor of introducing him. He is currently working as additional professor of hepatology at Institute of Liver and Biliary Sciences. He is the in charge of hepatitis hemodynamic lab of the institute, and he is his expertise is in portal hypertension, ascites, complications, viral hepatitis, and acute on chronic liver failure. And again, he is very active academically, has more than 100 publications, including a very prestigious New England Journal of Medicine, Lancet, Gut, Hepatology, Journal of Hepatology. These are all very high impact factor and very difficult to get publications in these journals. Again, he is very proficient and excels in performing complex ERCP procedures and transjugular biopsies. He also has undergone observership in Virginia Commonwealth University, Richmond, US, and Professor Arun Sanyal and his team on liver transplant, basic and clinical research methodology. And he's been awarded with several awards, National Scholar Award, United European Week, Vienna, and he's also a recipient of Rising Star Award. That's nice. From Asian Pacific Association for Study of Liver, and currently he's Associated Dean of APASL School of Hepatology. Over to you, Dr. Ankur Jindal.
Thank you, ma'am. Should I share my screen?
Yes, sir. Yes, sir. Please.
So you can share now.
Yeah. Are my slides visible to all of you?
Yes, you can switch to full slide mode.
Yeah, good afternoon, everyone. So the topic allotted to me this time is the management of the viral hepatitis. I think most of this has been covered by Dr. Archana, diagnostic part mainly, and the epidemiology. I will try to cover in brief the management part of viral hepatitis. As you know already, the viral hepatitis was initially defined as an infectious viral hepatitis, which was hepatitis A, and the serum viral hepatitis, which was hepatitis B and hepatitis D. Then there was discovery of non-A, non-B viral hepatitis, which included the hepatitis C, which was parenterally transmitted, and the hepatitis E, which was enterally transmitted. So there are basically two types of viral hepatitis. Either they are the fecal-oral route or enterally transmitted hepatitis A and E, and the serum hepatitis, which are transmitted by parenteral route and the sexual route, which include the hepatitis B and hepatitis C and hepatitis D. So we will go through the management of each virus one by one. Start with the hepatitis B virus. Before starting the management part, let us get used to the terminology which will help in deciding the management of the hepatitis B. So HBsAg. So when the patient is infected with hepatitis B, he is always have HBsAg positivity. So HBsAg positive is a marker of infection, and the patients who do not have hepatitis B infection has the marker anti-HBs. Anti-HBs is the antibody to hepatitis B surface antigen. which shows protection against the virus. Then there are markers of replication. With the HBsAg positive may be HBe antigen positive, HBe antigen, which is a marker of high replicative state. And then there may be the antibody to HBe antigen, which is a also low replicative phase, and most of these are the pre-core mutants. Then the past exposure is IgG anti-HBC, which is calculated by total anti-HBC if we measure in the blood. And HBV DNA is what we commonly call the viral load. So higher the HBV DNA, more the active viral replication is there. And then the ALT or the HB ALT or the SGPT is a marker of injury. So higher the ALT, more the active injury is there. It is a suggestion of immune response against the virus. So more the immune response, higher the ALT, and the more the liver injury. And then the fibroscan. So we have to measure the not only the virus status in the serum, but also the fibroscan and the liver stiffness. What is the actual severity of liver disease in a patient? So this is measured non-invasively by fibroscan or invasively by liver biopsy, which is a marker of liver fibrosis, which is very important. So the why HBV DNA is important in the management, because the higher the HBV DNA, higher the risk of complications related to hepatitis B. So you can see in this study, the higher the baseline HBV DNA, if DNA baseline is more than 6 log, if the DNA is more than million copies per ml at the baseline, then if these patients are not treated, then after a long period of time, almost 15% of them develop liver cancer. So higher the HBV DNA, more the chances of liver cancer in the future. Moreover, the baseline liver disease severity is also important, because not only the viral markers, the severity is important. The higher the severity, as we suggested by fibroscan, this is the more stiff the liver, more stiffer the liver. So, like LSM is more than 13, then there is more chances of developing the liver-related events. This is important because the hepatitis B and is one of the most common cause of development of liver cirrhosis and the liver cancer, which is called hepatocellular carcinoma. And the death from liver cirrhosis is most commonly attributed to hepatitis B, almost 30%, and death from liver cancer is 45% from hepatitis B. So the aim of the treatment for hepatitis B is to prevent the progression of liver disease, to progression from no fibrosis to fibrosis in a patient who is already having liver fibrosis, the prevention of development of cirrhosis, prevention of development of liver cancer. So briefly, the chronic hepatitis B, the phases Dr. Ekta has already covered. So most of the infections in the India is perinatal transmission. So from mother to child transmission of the hepatitis B. So most of the children, when they acquire the infection, develop the immunotolerant phase, which is now called the HBe antigen positive chronic hepatitis B infection. And in this phase of the hepatitis B infection, which may last up to 20 years to 40 years, depending on the immune response, the DNA will be very high. So most of the children who are infected with hepatitis B, as you can see here, they have very high DNA, but ALT is normal. So there is no liver injury. If we do the liver biopsy in those patients, in those children, then the biopsy will be absolutely normal despite the high DNA. So this is the scenario of immunotolerant hepatitis B. Over a period of time, almost 80% of them develop the E antigen positive chronic hepatitis. So E antigen will be positive in this phase, but their injury starts. So injury is, as I told earlier, the injury is highlighted by the ALT flare. So ALT will be high, it will be flare, maybe their flare is defined by the elevation of the ALT more than 3 times to or 5 times of the upper limit of normal. Then the higher the flares and more repeated the flares, the more the chance of liver injury and more the fibrosis progression in this phase. So then after a period of time, from E antigen positive chronic hepatitis, most of them develop inactive carrier phase. Inactive carrier phase is now called the E antigen negative chronic hepatitis B infection. From E positive, it becomes E negative. So if we do the serological test, the virus will be HBeAg negative. The DNA will be very low, less than 2000 or undetectable, and the ALT will be normal. So the most of the patients who are incidentally detected adults with hepatitis B infection are in the inactive carrier phase. They have low DNA, normal ALT, no liver damage, and the HBV DNA is less than 2000. Then some of the patients may have the E antigen negative chronic hepatitis. which is due to the pre-core mutants. Because of the HBeAg positive, it does not express. Then these patients also had the ALT flares and the liver injury. And our ultimate aim of the treatment is to achieve the HBsAg loss, which is very uncommon with the presently available therapy. And it is all spontaneous HBsAg loss is 0.5 to 1% per year. So the loss of HBsAg positive to negative is very uncommon, or less than 1% per year, and this is where we consider this patient as a cure of hepatitis B infection. Then, when a patient comes to us with hepatitis B infection, say if he is having HBe antigen positive, so the first aim of therapy is to achieve the DNA negativity. So to DNA negative, which is called the virological response. Then ALT should be normalized. It is called the biochemical response. And the aim of the therapy is to convert the E antigen positive to E antigen negative, which is called the HBeAg seroconversion from E positive to E negative. So this is called the satisfactory endpoint of the therapy. And ultimately, the ideal endpoint is the HBsAg loss from HBsAg positive to HBsAg negative, which is very uncommon with the currently available therapy. Among the patients who are already E antigen negative, the aim is to achieve the first DNA negativity, then the normalization of the ALT, and then the ideal endpoint is the HBsAg loss. The HBsAg loss is very important because it is associated with the prevention of liver fibrosis, prevention of liver cirrhosis, liver cancer, and improved survival. So any of the endpoint, if we are able to achieve, then it is good for the patient for preventing the further complications of liver disease. So not all patients of hepatitis B require therapy. So we need to select the patients who require therapy for hepatitis B. So there are some clear-cut cases where the treatment should be started at urgent basis, because some of these diseases which are life-threatening, like those patients who are having the acute liver failure due to hepatitis B infection, patient with decompensated cirrhosis, patient with severe flares of chronic hepatitis B. How to identify these patients? The patients will be present with severe jaundice, patient with encephalopathy, patient with ascites, patients with severe coagulopathy. So these are the patients with life-threatening disease with high risk of mortality. So these patients should be started on the urgent basis without waiting for the viral markers, the DNA reports in these patients. Then there are some patients which are having the very high risk of liver failure or liver cancer in the near future, like patients who are having the compensated cirrhosis and very high serum HBV DNA. As I told earlier, the higher the DNA, the more chance of liver cancer in the future. So in these patients, we should start the therapy as early as possible. The patients of HBsAg positive patients who are starting immunosuppressive therapy. So what happens when we start the immunosuppressive therapy, even if there is no liver damage at the baseline, with the immunosuppression, the virus will activate rapidly and may cause the liver reactivation and may cause the liver failure. So in those patients, like the patients who are on cancer chemotherapy and on screening found to have HBsAg positive, then we should, if we are giving the highly potent anti-chemotherapy like steroids or the rituximab or some other biologicals, then we should start the patient on therapy for hepatitis B to prevent the reactivation of the virus. Then there are non-cirrhotic population which are high risk of liver disease progression, like the patient with fibroscan value of more than 10, patient with advanced fibrosis, patient with extrahepatic manifestations. In E antigen positive patients with high ALT DNA more than 20,000, and E antigen negative patients ALT more than 2 times and DNA more than 2,000. So as a general rule, in a patient who is non-cirrhotic, if the DNA is more than 2,000 or 20,000 and ALT is almost 2 times of upper limit of normal, we should start the therapy as soon as possible to prevent the progression of liver disease. Then it is a dilemma whether to select the patient or treat all the patients. So current regimen is to start the therapy as per the guideline when the liver disease is advanced, when there is development of cirrhosis, because our aim is to prevent the development of decomposition of cirrhosis or prevention of liver cancer. But now the current concept is to try to treat all the patients of hepatitis B who are HBsAg positive, irrespective of DNA, irrespective of the ALT level, irrespective of fibrosis, because early antiviral therapy may prevent the progression of liver disease, may prevent the transmission of the hepatitis B virus to other population. And also the studies have shown that even if the patient is having the no significant liver damage but HbSAg positive, there is high risk of development of liver cancer in the future if the patient is lost to follow up, because most of the patients are asymptomatic. Then what are the therapies, current treatment strategies we have? So first one is the PEG interferon therapy for hepatitis B infection. The advantage of this therapy is it is a finite duration of therapy. So interferon can be given weekly, subcutaneously for maybe 48 weeks, and it is a finite therapy. And there are when we give the interferon, we need careful monitoring for the adverse effect, because some of the patients who cannot tolerate interferon. There are a lot of malaise, fatigue with interferon, lot of cytopenias may be there. And the beauty of the interferon is that there is off treatment response also. So the many of the patients develop the HbSAg loss even few years after the use of interferon therapy. So HbSAg clearance, there is maybe incremental increase in the HbSAg clearance over a period of time. The DNA suppression may be there, and the sustained virological response may be there with the use of interferon therapy. Then the most common therapy which we use is the nucleoside analog. What are nucleoside analog? These are oral medications which are given daily, once daily. Like tenofovir is the most common. Tenofovir, now the newer compound, the tenofovir LFNamide, which is called TEF, is the most common drug which is we use for hepatitis B. Then entecavir is another potent nucleoside analogs. Earlier we used to give lamivudine, which is now obsolete therapy and should not be given because of high risk of resistance. So, in how to give the nucleoside analog, these drugs are given on daily basis, and the aim is to achieve the HBV DNA decline to negative, because if the DNA can be declined to negative status, then there is a very low risk of transmission of the virus and very low risk of progression of liver damage. But the interferon, unlike but the nucleoside analog, unlike the PEG interferon, has the very low risk of HbSAg seroconversion. So HbSAg seroconversion, HbSAg loss, which is the ideal endpoint of the therapy, could not be achieved with the use of the tenofovir or entecavir. And moreover, these therapy need to be given lifelong, almost lifelong, because when we stop this therapy, there is very high chance that the patient may have the relapse of the virus. The DNA may increase in these patients, and there may be flares of the hepatitis, and there may be reactivation. Then what is the efficacy of the antiviral therapy? So PEG interferon therapy, if we give the therapy for 12 months, and after the 6 months of the end of the therapy, if we see the ALT normalization can be achieved in almost 32 to 40%. The HbSAg loss is 3 to 7%. But the important part is even after the stopping of therapy, 3 years later, the HbSAg loss is up to 11%. The studies have shown that up to 10 years later, the response may be almost 20 to 30%. So there is off-treatment response with the PEG interferon, unlike the patient with nucleoside analogs. If we see the patient with TAF, or TDF, which is tenofovir, then 1 year response, the HBV DNA negativity is almost to 3/4 of the patient, 76%, and at the end of 10 years, it is almost 100%. The HbSAg loss is almost 3%. So there is very low HbSAg loss with the use of tenofovir, but very high chance of HBV DNA decline with the use of nucleoside analogs. So the barriers of hepatitis B cure is, one is that the virus, unlike the hepatitis C virus, hepatitis B virus is integrated virus, very difficult to get clear completely from the liver, in the body. And moreover, in the active hepatitis B infection, the immune responses are very weak against the virus. So there is exhausted immune response against the virus, which lead to very high chances that the virus cannot be clear. The nucleoside analog which we give for our patients act on the polymerase, but do not target the cccDNA or the hepatitis B virus in the HbSAg. Thereby, the HbSAg loss is very minimal. The DNA may be declined quite often. So still the long-term antivirals are desirable in those patients we give therapy. The studies have shown that if we give the hepatitis B medications in a patient who is having advanced fibrosis, say the patient is having cirrhosis, or compensatory cirrhosis, if we give the therapy for a few years of time, then there is high chance of regression of fibrosis. Even some of the studies have shown that there may be regression of cirrhosis in many of the patients. So it is a good to give therapy for a long period of time, because now the drugs are very cheap, very easy to get, and they are very effective without any major side effects, and they may lead to regression of fibrosis in many of the patients. There is a decreased risk of development of liver cancer, almost 50% decrease in the chances of development of liver cancer over a period of time if we give the therapy in patient with cirrhosis. And the chances of developing of decompensation of the cirrhosis and ACLF is very low if we give the timely initiation of the antiviral therapy. The only lacunae is the duration of therapy. It need to be lifelong, and the cost of the therapy, because still the cost is of nucleoside analog is around 800 to 1000 rupees per month. So it is a lifetime cost, every month 1000 rupees. And adherence, because patients are mostly asymptomatic, so long over a period of time the patient think that they are not having any symptoms and the DNA is low, so they stop the therapy. Many of the patients have the adherence issues, and in high risk population there may be a safety issues like the patients who are elderly issues and patients who are comorbidities like the renal injury. So some of the patients have the renal related events, although they are very uncommon side effects with the nucleoside analog therapies. And the moreover with the newer antiviral therapies like the TAF, like tenofovir, lefenamide, the chances of the renal adverse effect or the osteoporosis are very uncommon. Then one special scenario I want to touch is the hepatitis B, the management in the pregnant woman and the newborns. And the most of the transmission of hepatitis B from mother to child occurs in the perinatal period. Almost 90% of the time, 80 to 90% of transmission occurs during the delivery, and some of the transmission may occur in the intrauterine infection period due to minor laceration of placenta, placental infection, as well as infection of the peripheral blood leukocyte. So these are the uncommon routes of the transmission from mother to child, and sometimes rarely during the child care or the during feeding. So there may be chance of hepatitis B transmission, although they are very uncommon. The important part is that the neonates who acquire the hepatitis B infection, most of them develop chronic hepatitis B infection, unlike the adult patients who acquire the hepatitis B infection develop jaundice and they improve. Almost 95% of the adults who acquire the hepatitis B infection horizontally clear their viruses, but neonates develop chronic infections and they are at a high risk of development of future cirrhosis and the liver cancer if they are left untreated or undiagnosed. So the prevention of mother to child transmission is by immunoprophylaxis. So all newborns should be given hepatitis B immunoglobulin at the birth, preferably within 12 hours of the birth, 100 international unit, plus first dose of vaccination within 12 hours of the birth, and complete the hepatitis B vaccine dose 016. And almost 95% of the patient can achieve the antibody titers over a period of time of the newborns. But some of the failure of reasons for the failure of the immunoprophylaxis is the high HBV DNA in the mother. If the mother DNA is more than 6 log, despite the immunoprophylaxis, there are some chances that there may be transmission of the virus. Failure to complete the vaccination course, delayed prophylaxis, and HBsAg surface mutants. So, who are the pregnant women who require the antiviral therapies? The pregnant women who are cirrhotics, the woman who had the prior failed immunoprophylaxis, prior threatened preterm labor, and those who have the HBV DNA levels more than 6 log, 5 logs at the 26 to 28 weeks of gestation, they should be initiated on antiviral therapy, preferably the tenofovir, because it is a class B drug, quite safe drug, and there are a lot of studies on that, and it prevents the transmission during the natal period. Now, coming in brief about the hepatitis C virus and the hepatitis A and E virus. So, hepatitis C virus, there is global burden is there. Hepatitis, as told by Dr. Archana, the hepatitis C infection, almost 6 million individuals are currently viremic for hepatitis C infection in India. And most of the individuals develop chronic hepatitis C infection after the exposure. Almost 2/3 of the individuals develop chronic infection, and most of them are asymptomatic. And over a period of time, they develop cirrhosis and liver cancer. Almost 20 years after the 20 years of period, so almost 20% of them develop liver cirrhosis, which may prone these patients to develop decompensation and liver cancer. So the aim of the therapy for hepatitis C infection is to achieve the SVR, sustained virological response, which is defined as the undetected SCV RNA after 12 to 24 weeks after the completion of therapy. So now we have the drugs which are available, which are very easily available oral medications taken once a day for 12 weeks to 24 weeks, depending on the regimens. And these patients can be easily cured of the hepatitis C completely. We test the SCV RNA after the completion of therapy 3 months later, and look for the SVR. And SVR is important because it prevents the decreased transmission of the virus and improve the clinical outcomes of the patients. So earlier we used to give the PEG interferon with ribavirin as a standard of the care. These therapies were poorly tolerated by the patients, and the response rate was also very modest. Almost 50% have the response. But with the newly available directly acting agents, which acts against the surface antigens of the structural proteins of the virus, so they have the very good efficacy. Almost 95% of the patients can be cured of the virus. So current regimen is to give the directly acting agents. The major drugs are the sofosbuvir and velpatasvir, which are the current standard of the care. Sofosbuvir plus velpatasvir, which is given once a day for 12 weeks in most of the patients. In some of the patients who are having decompensated of the cirrhosis, a very advanced cirrhosis, or patient who had the previously failed therapy, we need to give the therapy for 24 weeks. Otherwise, standard of the care is to give the therapy for 12 weeks once a day, regularly, without any requiring any on treatment monitoring. And almost 95, more than 95% of the patient can achieve the SVR rates. Then the reason for the failure in some of the patient is the relapse of the virus due to the SCV viral resistance, which is very uncommon with the currently available therapies. And even in the patient who have the decompensation of the cirrhosis, we need to give the therapy in early stages, because it will prevent the further progression of the liver disease, prevent the development of liver cancer, improve the quality of life, and it may prevent the liver transplantation of these patients. But in patients who are having the advanced cirrhosis requiring liver transplantation, so better is to go ahead with the liver transplantation and give the antiviral therapy after the liver transplantation. So some of the patients have the poor response to antiviral therapies for hepatitis C, like the patient who have hepatocellular as liver cancer at the baseline. So response rate is somewhat lower in these patients, but giving the antiviral therapies in a patients with hepatitis C prevent the development of liver cancer in the future. So in a patient, many of the patients have the co-infection with hepatitis B and hepatitis C. So in those patients, we need to give the hepatitis B therapy prophylactically, because when we start the therapy for hepatitis C, then there may be reactivation of the hepatitis B virus and there may be flares. So the summary for hepatitis C management is directly acting agent is a major breakthrough in last 10 years. And stage of liver disease is more important than the SVR, because anyway we can achieve the SVR. Almost 95% of the patient can achieve the SVR, but it is stage of the liver disease which is important for outcomes. We should not give PEG interferon or the other ledipasvir, dogletasvir based therapy. Standard regimen is sofosbuvir plus velpatasvir combination therapy for 12 weeks period, and optimize the response in some of the patients by adding ribavirin or extending the duration from 12 weeks to 24 weeks. And in decompensated cirrhosis, add ribavirin. And transplant candidate, in those patients who are transplant candidates, first get the liver transplantation, then start the therapy, and monitor the patient for hepatitis B reactivation and development of liver cancer and recurrence of the hepatitis C infection. I think shortly I will go through the hepatitis A and E viruses. These are the fecal-oral transmitted virus, which are commonly we see in our general OPDs. And coming to the hepatitis A infection, it is very high prevalence in Indian population. So most of the individuals are exposed to hepatitis B, already exposed to hepatitis A infection. So almost 90 to 95% have the anti-HIV seroprevalence. Regarding the hepatitis E infection, India is one of the endemic area where more than 25% of the AVH are hepatitis E related. But more recently, in last 3 to 4 years, we see more and more of hepatitis A, less of hepatitis E infection nowadays. The route of transmission are close personal contact. So hepatitis A transmit like one children in the family have the hepatitis A infection. So it may, or he goes into in the daycare center. So he may lead to, and they have the common kitchen, so they can transmit the hepatitis A infection to other individuals through the fecal-oral route. And household contacts, sexual contacts are the other route of transmission. Contaminated food and water, infected food handlers, eating a lot of street food post rainy season. These are most common cause of hepatitis A and hepatitis E infection. Rarely maybe blood transmission or sexual transmission, but these are very rare causes of transmission of hepatitis A and E infection. The incubation period is almost 2 to 4 weeks from the infection to the symptoms, and the most of the infection occur in the childhood, less than 6 years of age, and most of the individuals are children are asymptomatic. Almost less than 10% develop jaundice. However, those adult, if they acquire the hepatitis A infection or E infection, most of them develop jaundice. 80% are symptomatic with jaundice. Some of the patients may develop prolonged cholestasis. Some of they have the prolonged course of almost 3 to 6 months with lot of itching, progression of jaundice, but ultimately they recover. Some of they or less than 1% develop fulminant hepatitis, which is characterized by the acute liver failure, development of encephalopathy. And these are acute self-limiting illnesses, and most of them have no chronic sequelae. Well, as I said earlier, the onset is abrupt. Duration lasts for 1 to 2 weeks, sometimes lasting for months, especially in those with severe itching, and rarely fatal, except in patients who are having acute liver failure, which require liver transplantation. Children are generally asymptomatic. 5 to 10% have jaundice. 1 to 2 weeks duration is the illness, and adults are usually symptomatic with jaundice. And greatest activity is 2 weeks before the jaundice appearance, and greatest viral shedding is greatest during the late incubation and prodrome. The hepatitis C, the peculiar point is in the pregnant women when they develop jaundice in any trimester, they should be screened actively for hepatitis E infection, which is very common in pregnant women out of the many causes of jaundice. And the pregnant women are highly susceptible to hepatitis E infection with high attack rate due to hormonal imbalances. And they are more symptomatic, more risk of liver failure, and more risk of liver failure, acute liver failure in late pregnancy with high case fatality rate. Almost 50% have mortality, and high fetal complication, neonatal complications, and mortality, and high rates of vertical transmission, and no specific medication is required. And they should be carefully screened and carefully managed. And some of the cases may require liver transplantation also. The prevention of hepatitis A and infection is immunization for hepatitis A. Now in India, for last 1 month, we have the hepatitis E vaccine also available, and improvement in sanitary condition, clean drinking water, avoid outside food, proper sewage disposal, public education, awareness, defecation habits, hygienic habits. So these are the main ways to prevent the hepatitis A and E infection. And for hepatitis A infection, we have the pre-exposure prophylaxis, mainly the hepatitis A vaccine, which should be given. I think in current scenario, it should be given to all individuals, although it is not in the guidelines to give the hepatitis A vaccination to all individuals. It is restricted to people planning to travel to endemic areas, men who have sex with men, illicit drug abuse, patient with chronic liver disease. So these are the high risk individuals. We should be given the pre-exposure prophylaxis. But I think in the current scenarios, with the cheaper vaccination which are available, which are very safe, we should give to all the individuals. And the vaccine is the Havrix vaccine, which is an inactivated vaccine, which is two-dose vaccine given at 1 year and at the 6 month after the first dose. And it is very effective, 95% immunogenic, and and very lesser side effects. Now there is a live vaccine also, which is given at 6 months of age. Post-exposure prophylaxis is now obsolete, and it is earlier given after the exposure, and it provides immunity for 1 to 2 months. Now the pre-exposure prophylaxis, if given, may give immunity within 10 to 15 days. So there is hardly a role of post-exposure prophylaxis for hepatitis A infection. The hepatitis E vaccine in India is currently now available. This is by the name of Havrevic, and it is a recombinant hepatitis E vaccine approved for individuals for 18 to 65 years of age. 3 doses for 0 1 6 months, and vaccine has showed good safety and immunogenicity in Indian studies with no adverse effects. I think this is I have covered, try to cover in brief the hepatitis B, all the viruses. If you have any question to us, then I can answer.
Thank you, Dr. Ankur, for comprehensive presentation on management of viral hepatitis. I think a lot of new things have happened over the years. The participants would appreciate the changes in the current guidelines, the new vaccines which are now available. If there are any questions, you can write in the chat box. While they are writing, Dr. Ankur, would you stay with us for the?
I need
Now,
to go to OPD now.
I know you told me that.
We can have the question, 2 3 questions maybe right now.
Yeah, okay. Quickly, can you write the question here, because he has a OPD and he was kind enough to agree to take this session, and you will also appreciate he was the best person to take up this session today. Working right in the actively in the field, managing these patients. How to treat C and B co-infection? Which worst?
Yeah. So this was a question which was commonly asked previously before the advent of the newer therapies, because now the newer therapies are very safe and effective. So if the first we have to see whether the virus is active or not. So if the SCV RNA is negative, and the patient do not need anti-SCV therapy. For hepatitis B infection also, we need to see whether he fulfills the criteria for hepatitis B infection. Otherwise, if the HCV is positive, HCV RNA is positive, then we need to give the antiviral therapy for 3 months for hepatitis C, and also give the tenofovir for hepatitis B, because there is chances of reactivation of the hepatitis B infection if we give the anti-HCV therapy. So HCV therapy only if the virus is active. HBV therapy only if we are giving the HCV therapy, or if there is treatment indication for hepatitis B.
Okay. What is the mechanism of a action of TDF?
Yeah, these are the polymer. The, these are the polymerase inhibitors. So these act and on the very late phase of the viral life cycle. They decrease the DNA. It prevents the viral replication, but it has minimal effects on the surface and the core, the cccDNA, which is in the nucleus of the virus. So it mainly acts on the polymerase.
Okay. Then there is a question on HBsAg positive undergoing surgical procedure. What is the indication?
HBsAg positive surgical procedure. So if we need to see whether the patient is having the DNA positive or no, and the stage of liver disease in this patient by fibroscan or any other measure. If the patient is having the HBV DNA is negative, and the fibroscan is also normal, then we can go ahead with the surgical procedure. If the DNA is high, first, depending on the urgency of the surgical procedure, if it is urgent, then we start the surgical procedure. Otherwise, we start the antiviral therapy, let the DNA decline to less than 2000 or preferably negative, and then go ahead with the surgery. And if the patient is having the advanced fibrosis or cirrhosis related to hepatitis B, then we need to start the therapy as early as possible, and go ahead with the surgery depending on the indication.
I hope it answers your question. Let's move to the next question. Is there any role of herbal or Ayurvedic medicines in chronic hepatitis B infection?
Yeah, we discourage use of herbal and Ayurvedic medication because some of the medications which are available over the counter and not prescribed by the appropriate physicians may have the products which may lead to reactivation of the hepatitis B virus, and mainly steroids or some products may lead to reactivation. So we discourage these practices unless prescribed a uh, by approved physician.
How to manage vaccine escape mutants of hepatitis B virus?
Yeah, so vaccine escape mutants are very common. So if they are vaccine escape mutants, then the antibodies will be negative, and we need to give the the booster dose of the vaccine in these patients, and then monitor these patients.
Okay, then there is another question on for pregnant women with high viral load, hepatitis B and hepatitis C, when should we start treatment?
Yeah. So for hepatitis B, general guideline is to start the antiviral therapies at the 26 to 28 weeks of gestation. But even if we start the therapy early, maybe in the second trimester, it is also safe, and it might also prevent the intrauterine infection also. For hepatitis C virus, there are no there the the efficacy and safety of the directly acting agent for hepatitis C is not established in pregnant women. So there is no way we can prevent, and there is no vaccine for hepatitis C also. So just we need to monitor the baby after birth.
Okay. What is the preferred treatment for pregnant women found to be positive at 30 weeks?
Yeah. So most of the pregnant women do not require antiviral therapy because the DNA is generally very low. But if the DNA is high, we give the antiviral therapy. The preferred drug is the tenofovir. And tenofovir should be given up to 6 weeks after the pregnancy, after the delivery, because there is if we taper the tenofovir early after the delivery, there is a chance of the viral flares may be there. So it should be stopped very carefully and with careful monitoring.
Okay. Then how do you follow old case of hepatitis A, whether through LFT or immunology test?
I think there is no need to follow the old case of hepatitis A because most of us are already exposed to hepatitis A infection, either asymptomatic or symptomatic. So uh, there is no guideline to suggest we should do the antibody titers for hepatitis A infection. If we need to do, then total antibodies, HIV antibodies may be done.
Fibroscan, contraindication in pregnancy. Why?
I think fibroscan is not a contraindication in pregnant women. It is a ultrasound based measure, unless uh, we are doing it in very late trimester because of the uh, because because it will not be feasible at that point of the time uh, sometimes. But otherwise, it is not a contraindication in pregnant women.
Then there is one question on accident needle prick with hepatitis B positive blood.
Yeah. So first, I will go through all the viruses, like mainly the needle stick injuries with hepatitis C and hepatitis B. For hepatitis C, I think there is no vaccine available, no immunoglobulin available. So what we can do is to check the individual viral load, the infected individual viral load. If the HCV RNA in the infected individual is negative, then there is very low risk of transmission of hepatitis C infection, and we need to carefully monitor. If the SCV RNA of the infected individual is positive, then what we can do is after 2 weeks of the needle stick injury, then we can do the SCV RNA. because SCV RNA takes 2 weeks to come positive. And then if SCV RNA is positive, then we need to take the directly acting agents. Otherwise, we need to serially monitor the SCV RNA, because sometimes the SCV RNA may occur, may develop later on, maybe after 1 month or so. Anti-SCV takes 6 weeks to 12 weeks, so it appear very late. So best is to monitor with SCV RNA, because the therapy is based on SCV RNA. So if once the SCV RNA is positive, then only we need to treat. For hepatitis B infection, if the source is HBsAg positive and DNA is positive, then we need to give the immunoglobulin as early as possible. And also we need to know the antibody titers. If our antibody titers, the patient who is pricked for a needle stick injury, so if antibody titers anti-HBs is more than 10 or more than 100, then very low risk of infection is there, and we need not worry, and complete the HBV vaccination course if not done previously. And if the anti-HBs titer is less than 10 and the individual who is infected source is positive, then we need to take the immunoglobulin and complete the dose of vaccination.
If there are any missed doses of hepatitis B vaccination, should it be repeated or taken as when remembered? Or
Yeah, I think like say 2 doses you have taken and and the third dose is missed at 6 months. So uh, if it is 1 or 2 months missed time, then you can take the third dose. And if it is long before in years, then best is to do the anti-HBs titer. If anti-HBs titer is more than 100, I think no need to worry and take the third dose.
any advice on marriage for patients who are hepatitis B positive?
Yeah. Now, this is a very important question, because many of the individuals who are about to get married and have the this doubt. So, we suggest to start the antiviral therapy in such individuals, because the antiviral therapy is very safe, and it is an oral medication, very safe, and it will keep the HBV DNA negative, so that transmission will not occur. And also we advise to get the partner vaccinated, so that the partner anti-HB titer is more than 100, so there is a less risk of transmission.
Any advice on breastfeeding after delivery?
Yeah, the hepatitis B vaccination, the breastfeeding is generally safe in HBsAg positive mother.
Is there any medicine which can save liver disease?
What do you mean by saving liver disease?
I think liver damage, drugs causing liver damage are known, but I don't know if there are any drugs which can save you from viral infections.
Yeah, vaccines are the only drugs which can prevent the viral infection and prevent the liver damage.
There's just quick question on dialysis and directly acting antiviral agents.
Yeah, there are studies. Directly acting agents can be given for SCV infected individuals who are on dialysis. They can be given very safely with good response. We have published in 2018 our data also, and with that time there was a drug by sofosbuvir and ledipasvir, and the drug were very good tolerated. And after the dialysis, we can give the medication, and the response rate is almost 95%.
There's a question about monitoring of HBsAg plus and viral load not detected. Next, monitoring of viral load.
Yeah, generally it is recommended to get viral load every 6 months to 12 months. Those who are asymptomatic, normal ALT, HBsAg positive, E antigen negative. So most of these are inactive carriers, and they need viral load monitoring, maybe 6 months to 12 months, and ALT monitoring also every 3 to 6 months, because sometimes there may be intermittent flares of the virus may be there. So this is why, to prevent these repeated monitoring, so we also propose the treat-all approach. If those who are HbSAg positive, irrespective of other parameters, start therapy, it will. So even if you miss the monitoring, because the DNA is DNA E antigen monitoring, fibroscan monitoring, so these require cost. So in that cost, we can give the antiviral therapy. So better to treat all the patients for HbSAg positive, although this is not in the current guidelines.
Okay, I think Dr. Neeraj Gupta is already there. We have had a thank you for taking up all the questions. There is one question about contradictions, indications of drugs during treatment of hepatitis B.
So I think these newer drugs like TAF are generally safe and without any drug-drug interactions. So most of all the drugs can be given safely with tenofovir. There's no significant drug-drug interaction requiring discontinuation of therapy.
Thank you, Dr. Ankur,
Thank you.
for such a lucid presentation and taking up all the questions with the clear answers. I think the participants were enriched by the answers, and they will apply this in clinical practice as well. Thank you once again.
Thank you, sir. Thank you.
Sir, please stop sharing, sir, the screen.
Yeah.
Now we have next speaker, Dr. Neeraj Gupta. He is professor and head at Department of Pediatrics at AIMS, Jodhpur, and he will be talking about neonatal jaundice. I think this is a very, very pertinent topic to all the participants. We have Dr. Neeraj, we have a mixed participants here from all the levels of healthcare, right from primary care to even faculty from tertiary care hospital is also with us, and we have around 50% participants, nurses as participants here. So I hope they will also, because many of these health facilities are manned by these nursing staff, so this topic is very, very relevant to them. As I told you, Dr. Neeraj Gupta is a professor and head Department of Neonatology at AIMS Jodhpur, and he actually is the founder of the Department of Neonatology at AIMS Jodhpur, and he received RCPCH visiting fellowship, and again he has more than 70 publications including Cochrane Review, several book chapters. He has been contributing to WHO guidelines, ICMR standard treatment workflows, FBNC modules, and NNF clinical practice guidelines. And he's been very actively working on extramural projects with funding worth 8 crores. That's a huge amount. That must be a very, very prestigious, huge project. And he's been guiding several students receiving awards at NeoCon, IIP, NeoCon, IJP, Best Thesis, and Big Birak grant. And that's quite an honor to get this Birak grant. Over to you, Dr. Neeraj Gupta.
Thank you, ma'am, for the kind words, and namaskar to everyone. So let me first share the presentation. Is my slide?
Yes, sir, it's visible.
Okay.
It's visible, sir.
Thank you so much. So first, I would like to thank NHSRC and Sangeeta ma'am especially for giving me this opportunity. So before me, Dr. Ekta and Dr. Ankur were talking about viruses. So I'll slightly change the focus to the Homo sapiens sapiens. And before we impinge on, just a food for thought. If you see newborns, I think rarely you'll find a newborn in the early phase in first 3-4 days where you will not find jaundice in the newborn. More than 90% of the babies will find there is some degree of jaundice. So if jaundice is so much prevalent, so then why nature decided to give? Because usually what happens, what is there more prevalent in the nature, it means that is actually normal. And here we are going to talk of something that then why it becomes pathological, why it is creating issues. And the reason is that bilirubin in the body, actually it acts as an antioxidant. So in newborns who are prone for diseases, especially free radical injuries, this bilirubin acts as an antioxidant. And that's why nature decided to have bilirubin, a lot of bilirubin in most of the newborns. Only when the bilirubin crosses some range, then it can cross the blood-brain barrier and can damage the baby's brain, and which can cause neurodevelopmental issues and a long-term handicap. We want to contribute to the society in form of productive members of the society rather than adding burden to the society. So that's the basic reason. So over the next 30 minutes or so, we'll discuss about how to differentiate between physiological versus pathological jaundice. We'll see the various guidelines and what are the various treatment modalities which are available to us in the treatment. Before we go to the jaundice per se, let us be very clear about the two very basic terms. One is hyperbilirubinemia. As the name says, hyper means high. So when the bilirubinemia, what we use for the blood, anything in the blood. So if the bilirubin levels in the blood are more, that is called as hyperbilirubinemia. So normally the serum bilirubin which we take is normal is less than 1 milligram percent or 1 milligram per deciliter. If it is above that, we call it as hyperbilirubinemia. Now another term is jaundice. So jaundice means that if because of this increased bilirubin, there is a yellowish discoloration of skin and sclera, then that's we call as jaundice. Now you'll find that in newborns, what happens when we start seeing their jaundice, usually it appears on the face, and by the time it is clinically evident in terms of the visibility on the face, the levels are actually beyond 5 milligram per cent. So that's the basic difference. So anything above 1 is called as hyperbil only when it is going to cause staining, which means anything between 1 to 4 will not be visible. It will still be labeled as hyperbil, whereas clinically the baby will not look a trip to you or will not be jaundice. Now there are two kinds of jaundice. The previous speakers where they were talking of all hepatitis, viral hepatitis, that primarily leads to conjugated jaundice. In this next session of 20-25 minutes, we'll be focusing only and only on the unconjugated variety of hyperbilirubinemia or jaundice, which we see in humans. I'm not going to discuss on the conjugated because the approach is entirely different. The differentials are entirely different. And it is very interesting that this is the only age in newborns where we see jaundice as physiological. We label it as physiological. We don't label it as pathological unless it fits into some criteria. And whereas in other age group, in no other age group apart from newborns, you'll find that the jaundice has been labeled as physiological. Now coming to the overall incidence which we see, as I said, more than 80 to 90%, though the books mention 60-70%, if you actually see, based on my own experience, more than 90% of the babies when we take rounds in the maternity wards will find that they have jaundice. In preterms also it is even higher than that, and even a lot of babies we see at 1 month of age who are exclusively breastfed, still you will find that they are ectric. But having said that, it is also one of the common reason of readmissions after discharge. And though, as I said, that most of these are physiological, but our evaluation must always focus on the pathological because that is the chunk which we need to prevent. If I see, let's say, 100 babies in my maternity ward, out of that 90 babies will have jaundice. And out of these 90 babies, 10 to 12 babies are those who fits into this pathological criteria and need treatment primarily in form of phototherapy. That's the overall thing, which means whatever number of babies we see as jaundice in these apparently healthy babies, almost 10 to 12% or 15% are pathological, which needs some intervention. So question is that why we want to detect this early. The reason is very simple, as I said earlier, that after some level, when it crosses, in the levels are high in the serum, it crosses the blood-brain barrier, and once it crosses the blood-brain barrier, it enters into the basal ganglia and allied areas of the brain and causes the permanent damage of the neurons, causing necrosis, which manifests as what is called as acute bilirubin encephalopathy in the acute phase, and the long-term sequelae of this acute bilirubin encephalopathy is known as Kern icterus, that is Kern icterus. Kern means nucleus, the basal ganglia, icterus means staining, the yellowish staining. So yellowish staining of this basal ganglia is labeled as kernicterus. And what it manifests? It manifests in form of cerebral palsy, the dystonic kind of cerebral palsy. Basically, these babies have choreoathetoid movements, they have sensory neural hearing loss, their cognition is low, there is enamel hypoplasia. There's a combination of that. So we do not want to add burden to the society. It will create problems, it will lead to long-term neurodevelopmental sequelae. That's why it is important to identify those 10 or 12 odd babies who are going to have pathological jaundice among this cohort of so-called apparently looking physiological jaundice. Now, if we see the pattern of this jaundice, the physiological jaundice, it follows a cephalocaudal progression. What it means? It means that it starts from the head and neck area and it moves to the trunk and to the lower limbs and to the palm and to the palms and soles. Why so? There are multiple hypotheses which people have postulated. No one knows what is the exact reason, but this is very typical in newborn jaundice that it progresses from cephalic to caudal area, and that also helps in our clinical judgment when we use the Kramer's rule, which we are going to discuss. Physiological and jaundice doesn't appear in the first 24 hours, it appears after 24 hours, and usually by third to fourth day, it reaches to the maximum, and automatically after the fourth day, it starts decreasing and usually disappears by 14 days of age. That's the usual course of physiological jaundice. I hope the slides are moving.
Yes, they're moving.
Thank you.
Yes, sir.
Thank you. Now, when to suspect pathological jaundice? So, as I said, if the jaundice is appearing or when the baby is icteric before 24 hours of age. So, any baby, because a lot of ASHA workers, the nursing officers, medical officers are there. So, if the jaundice is appearing before 24 hours of age, if you are finding a baby whose palms and soles are icteric, if the bilirubin is beyond 95th centile, so there are nomograms which we are going to discuss.
I think we lost you, Dr. Neeraj.
Ma'am, am I audible? Ma'am, am I audible?
Yes, sir. You are audible.
I think there may be some network issue then. So is my audio clear now?
Yes, sir.
Okay, thank you.
Uh-huh.
So if the bilirubin is beyond 95th centile for that given age in the age specific nomograms, so there are some nomograms which are available. So we'll discuss that. So if it is above that or the rate of rise of bilirubin, you have two bilirubin levels, and if it is crossing 0.3 milligram per deciliter per hour in the first 24 hours or beyond that is considered pathological. Any baby you are finding who has subtle features of acute bilirubin encephalopathy, which is also called as bilirubin induced neurological dysfunction or damage, all these suggest that this baby has pathological jaundice. It is not physiological, and treatment should be started immediately. Similarly, it is very important to know that if a baby has jaundice beyond 2 weeks of life in term babies and beyond 3 weeks in preterm babies, so till that time it can be there. As I said, that if you are seeing a baby in your OPD, let's say the baby was full term baby, and this baby is now day 18 of life and still the baby is icteric, it means it is pathological. This baby needs evaluation. Though a lot of these babies also turns out to be normal, but yes, it warrants immediate evaluation. And in preterms, we take this cutoff as 3 weeks to label it as prolonged jaundice, which is pathological. And it is again important to understand that any conjugated jaundice, irrespective of the age, is always pathological. Whether even if there is a conjugated jaundice on day 3, day 4, it is always pathological. So when we say physiological jaundice, it is only for the unconjugated variety. Conjugated is always pathological. So these are the broad criteria to say that yes, this jaundice is pathological. Now, what are the risk factors for this pathological jaundice? Any baby who is less than 40 weeks is, so especially I'm talking of the late preterms and early term population, is at high risk. If the simple question we ask the mothers, do you have any sibling, any baby? If yes, then whether the baby required any phototherapy or not. So the history of phototherapy in the previous sibling is very important because a lot of genetic factors are there because of which the current baby is also at risk for pathological jaundice. If there is some cephalometoma, which means collection of blood on the head, or there is some significant bruising because of the instrumental deliveries, so vacuum or forceps has been used at the time of delivery, which is causing trauma, is because so there will be blood collections, it will cause hemolysis, and there will be more bilirubin production. Exclusive breastfeed is something which we always promote, but if the intake is suboptimal, causing excessive weight loss, then it can increase the normal levels, causing pathological jaundice. Babies who are born to the mothers who have diabetes, whether it is type 2 diabetes or type 1 diabetes or gestational diabetes mellitus, all these babies are at high risk. And anything which, if there is a setting for hemolysis, whether it is RH isomination causing hemolysis or ABN compatibility, or let's say there is a family history of some sort of hemolytic disease, hemolytic anemias, all these are the risk factors where we expect that more RBCs are going to lyse, so more bilirubin production and more chances of pathological jaundice. So this is just a chart to show that what are the various broad group of etiologies, just to understand that there is increased production, decreased clearance, increased enteropathic circulation, and prematurity. Increased bilirubin production will happen if there is any kind of hemolysis, as I discussed, AB incompatibility, RH incompatibility, or there are some hemolytic anemia settings, whether it is enzyme defect like D6PD, or membrane defect like hereditary spherocytosis, or because of, let's say, collection of blood as like cephalometomas, polycythemias. Decreased bilirubin clearance, usually we see in Crigler-Nazar, or sometimes the mutation of this uroben glucuronide transferase enzyme. And when in the initial phase, when the breast milk intake is less, so the bacterial load in the gut is low, and a lot of this glucuronidase enzyme which is present in the cells, it breaks down and causes more enteropathic circulation. And of course, prematurity, all these functions are weak, which exaggerate. So these are the usual reasons which we see for pathological jaundice. Now, once I have a baby who has jaundice, how should I approach? So, which baby needs evaluation for jaundice evaluation? All newborns who are there at any health facility, whether it is primary health center, CHC, district hospital, or tertiary care centers, all babies in the first week of life needs evaluation, active evaluation for jaundice, because as I said, more than 90% of these babies have jaundice. And beyond first week, if the jaundice is persisting till resolution, this needs evaluation. When and how to evaluate for jaundice? When to evaluate? If the baby, if nowadays we are touching almost beyond 95% institutional deliveries. So most of the deliveries are taking place at hospitals. So in the hospital, after birth, every 12 hourly during rounds, each baby has to be inspected for the presence of jaundice. At home, those babies getting discharged then by the ASHA workers, or as per the advice, if the baby is going home and at day 3 or day 4 of life, then as per the doctor's advice, they have to come back. How to evaluate? The first and the foremost thing is by the visual inspection. We see that whether the baby looks ectric. This needs actually experience. Lack of experience is also one of the reasons that a lot of these jaundice gets missed. So once I found that this baby is ectric, I need to ask some questions in the history. What are those specific questions from the jaundice perspective? I need to ask for the family history of any hemolytic anemia or any liver disease like galactosemia. I need to look into the antenatal details, that whether this mother had anything suggestive of torch infections like fever, rash, and lymphadenopathy like neck swellings, arthralgias, and genital ulcers, or mother has taken some sort of drugs like sulfonamides, which can cross placenta and can cause bilirubin displacement in the baby. So displacement of the bilirubin from the albumin. The use of oxytocin exaggerates jaundice. If there is a history of instrumental delivery, then it can cause bruising, cephalometoma, subgaleal bleeds. All these can act as which can exaggerate this jaundice, causing pathological jaundice. And how is the feeding details of the baby and the urine output and stool? If the stool color is not changing to from greenish to yellow, the urine output is less than 7 to 8 times in 24 hours, or the baby's the mother says that the baby is not feeding well. All this shows that there is high possibility that the chances of pathological jaundice is more. So all these are the questions which one need to specifically ask while evaluating a baby who seems to have jaundice on visual inspection. In the examination, one need to specifically look whether the baby is appropriate for gestational age or small for gestational age, which means the birth weight is less for that given gestational age, microcephaly, because all these point more towards the torch infections, any bruising or cephalomatomas, any kind of blood collection in the body. If there is pallor, which means there is some evidence of either blood loss or the RBC is getting lysed, any evidence of hepatosplenomegaly or petechiae, again pointing towards torch infections. Same holds true for chorioretinitis and Down syndrome. So these babies are again at high risk of pathological jaundice. So what are the ways by which we assess jaundice? As I said earlier, that the first and the foremost is the visual inspection. So in the visual inspection, we follow the Kramer's route. If the person feels that, okay, with my expertise, this looks to me reasonably on the higher side, then one can use transcutaneous bilirubinometry or the total serum bilirubin. Let's go one by one. As you can see in the visual inspection, what is done is that the baby is taken close to the window. The light has to be proper and to the natural. It is very important. If the light is not proper, your assessment will be wrong. So what we do is we first press the forehead very gently. Remember that the pressure which you are applying through the fingers, as you can see in the photograph, pressing the sternum area. So it has to be gentle. It should not cause any kind of trauma to the baby. It should not cause the baby to cry. So it has to be gentle. You press it and release it. You press it for 4 to 5 seconds, say 101, 101, 102, 103, 104, 105, and you just release it. If the baby does not have jaundice, you will see that it is more of very light yellow color or blanching kind of color, which you can observe by pressing your thinner and hypothinner, that how it looks like. If the baby is ectric, then you can see in the photograph adjoining this that instead of that blanching or this light yellow, you will see the dark yellow part, which means the baby is ectric, which comes with more experience. So we move from sternum, forehead. If the baby is not ectric on the forehead, then there is no point to look at the sternum or the below area. But if the face is ectric, then you look at sternum. If sternum, then you look at thighs. If thighs, then you look at legs and then soles. Because as I said earlier, that the jaundice progresses from cephalo to caudal fashion. And by this, we are able to understand that what can be the reasonable level. So as you can see here in this photograph, this was devised by Dr. Kramer. So based on the extent, if the baby is only ectric till face, it is the level of serum bilirubin is likely between 5 to 7. If the chest is also there, it is like 8 to 10, and lower abdomen thigh is like 12 to 15, and then palms and soles beyond 15. But the problem is that this method can have fallacies, especially as if the experience is less, if the baby's complexion is on the darker side, if the light is not proper, and above 15, as I said, if the soles are ectric or the palms are ectric, then it can be any value above 15. And if the baby is under treatment, then again this therapy, this modality of assessment doesn't work. So these are the pros and cons of visual inspection. But the most common method which we use in day in, day out in our maternity wards or in the OPDs is your visual inspection. So this is just to highlight the IMNC algorithm. There also they say that apart from the other questions, if the mother is coming with the baby, one need to ask whether if there is any jaundice or not, and you have to look for jaundice. If the jaundice is, as you can see in the red, the topmost, the light pinkish or reddish, if the jaundice is in less than 24 hours, or if the palms and soles are ectric, it means it is pathological jaundice. So one need to immediately refer to the higher center. If the jaundice is appearing after 24 hours and the palms and soles are not yellow, then we give advice to the mother, and of course one need to actually see what is the bilirubin levels and like that. This is the standard treatment workflow which can be used at primary and secondary health centers. So what it says is that all the babies, if you see the rectangular boxes in the center, which are bluish greenish in color, so all the babies needs to be examined under the natural light or bright light. It has to be white light, not yellow light, and in a proper way, and assess the severity. And the same thing, the same Kramer rules they have shown, and they've also tried to highlight the same risk factors which we discussed. And if this baby is ectric in less than 24 hours, or the baby's palms and soles are ectric, or this baby is showing features of acute bilirubin encephalopathy like poor feeding, lethargy, tone changes, it means it is a pathological jaundice, serious jaundice. One should immediately start the treatment. This is just a simple algorithm that you are assessing the baby. So doing the routine rounds in the maternity ward, you, as I said, that all these babies need to be examined every 12 hourly for the jaundice. Apart from the other evaluation part, so if you find that the baby is ectric, ask yourself if this baby is less than 24 hours, if the are the palms and soles ectric, or is there any evidence of bilirubin encephalopathy. The earliest changes you'll find is poor feeding, lethargy, because in a newborn, if the baby becomes ill, then these are the usual features. So if nothing is there, then you just follow and do the serum bilirubin or transcutaneous bilirubin. If any of these things are there, you immediately start phototherapy and do the further evaluation. Second modality for assessment is the transcutaneous. Because of the limitation of visual inspection, the people came out with the transcutaneous. There you don't need to prick the baby. As you can see, two devices here. One is being pressed over the sternum, other is being pressed over the, not pressed, but just applied over the pinna, and it gives you some value. So values, the transcutaneous is used for more of the screening purpose, where there is doubt on the, you can say, your visual inspection or the expertise is an issue, the light is not proper. So a lot of units, universally people are using this modality, but there are limitations of this modality in the sense that you cannot use this device for babies less than 35 weeks of gestational age or in the first 24 hours of age, because the whole data, the evidence is beyond this. And second is the values you can rely if the values are up till 13 to 14. If the values are going beyond that, then the values which are coming in this device are not reliable. You need to actually go prick the baby, take the blood sample and look for the bilirubin. So this device is good from the screening perspective, but if the values are beyond 14 to 15 milligram percent, then we need to actually prick the baby. So the third modality by which we assess the jaundice is the serum bilirubin. What you need to do is you have to take the blood sample from the vein, or if you're using capillary method, then you have to prick the heel. So any jaundice in first 24 hours, any transcutaneous beyond 13 to 14 milligram percent, or if the values are in the charts which we discuss is close to the phototherapy, you are planning to start phototherapy based on that transcutaneous, you have to first confirm. These are the usual. And once you have started treatment, then the only modality to monitor the bilirubin levels is by pricking the baby, that is the serum bilirubin. In serum bilirubin, there are different methods. The commonest method is the middle method, which you can see, diazo method, which is based on the Van der Berg reactions, which we send to our biochemistry labs. The gold standard is HPLC, which is high performance liquid chromatography, which is usually not available. It is more of a research setting tool. Nowadays, a lot of units are using side labs where they use the first method, which is called as micro method, which gives you where we take the blood sample in the capillaries, but not in the, so this saves the blood also instead of taking in the vacutainer, and you immediately process it and gets the value within next 5 to 10 minutes and take decisions. So once I know that this baby has pathological jaundice, based on the nomograms which we just see or the criteria which we discussed, then we need to understand some other basic investigation needs to be done, like what is the blood group of the mother and the baby to understand any setting for RH incompatibility or ABO incompatibility. We need to look at the hematocrits, we need to look at the reticulocyte count and any evidence of hemolysis in the peripheral smear. The second line investigations includes the direct Coombs test to look for immune-mediated hemolysis, G6PD levels, liver function test, and as I said, there may be other reasons like torch, sometimes hypothyroidism, Krigler-Nazar, Gilbert, and all those kind of things. Those investigations needs to be done depending on the situation. This is just an overall evaluation. So just to highlight that if there is a jaundice which is pathological, do a direct Coombs test. If it is negative, it means it is you're not talking of, if it is positive, it means you are talking of immune mediated, which can be ABO incompatibility or RH incompatibility. If it is like mother's blood group is RH negative, baby is RH positive, that means there is a setting for RH, you go for this. If it is hemolytic jaundice, but DCT test, the direct Coombs test is negative, it means there can be G6PDs or abnormal membranes like spherocytosis, erythrocytosis. If it is not fitting into that, then you start looking for the other reasons. Now, once there is a pathological jaundice, what modalities I have to treat this baby? There are 3 modalities. Phototherapy is the most common, which is used virtually in all babies who have pathological jaundice. Where there is a setting for hemolysis, there we use intravenous immunoglobulins. And if the values of bilirubins are high, they are not coming down, or they are crossing some levels where we have fear that it can cross blood-brain barrier causing acute bilirubin encephalopathy, then we need to do the exchange transfusion where the blood of the baby is exchanged with the new blood. Phototherapy is the mainstay. There, the kind of light, the wavelength which we use is around 430 to 490 nanometers. There are various mechanisms, we'll not go into those details. So there are various devices. As you can see in this photograph, on the top side, you can see one light which is falling on the baby, the blue colored lights. And in the bottom, the picture, you can see there is some pad on which the baby is lying, which is emitting similar kind of blue colored light. So there are different kind of devices, some tubes, some this compact fluorescent lamps, light emitting diodes, and fiber optic blanket. The first one which you are seeing in the above is actually a LED, and the second one is the fiber optic blanket which you are seeing here. These you can see. So previously we used to use a lot of CFLs and tube lights, but now we have shifted to LEDs because it saves a lot of light. They are slightly costlier, but they saves their duration of life is longer. So ultimately it is more cost effective, and it also saves a lot of light. And the irradiance which is there is pretty good. Any irradiance which minimum irradiance of these phototherapy should be at least 15 microwatt per centimeter square per nanometer. And when we say high intensity phototherapies, it should be at least 30. So this is another thing. So when you give phototherapy, there are a few basic things which needs to be taken care. One is that all these babies needs to have bandage, eye bandage, where so that the light doesn't damage the eyes, the phototherapy light, and there has to be diaper to protect the genitalia. Some people have a notion that the genitalia has to be only for the males. In females, we put diaper more from the aesthetic perspective as well as from the to prevent the soiling of the bedding. That is the reason. So in both the genders, you need to put a diaper and the eyes has to be closed. Rest, make sure that the diaper size of the diaper is small so that the maximum body area gets exposed, and one should try to minimize the interruptions. Only the baby should be taken off phototherapy only for the breastfeeding. If the baby is sick, anyways, the baby will be on fluids or OG feeds, orogastric feeds. And as I said, that the baby should be as close to the phototherapy as possible to increase the irradiance. Maximum area should be exposed, and while giving intensive phototherapy, usually the irradiance should be at least 30 or more than 30 microwatt per centimeter square per nanometer. So when to start phototherapy? There are charts. So there are 3 kind of guidelines which we use. One is charts by the American Academy of Pediatrics, AAP charts, which came in 2022, which are used for equal to or babies who are equal to or more than 35 weeks. Or you can use NICE guidelines, though there is nothing nice about this NICE, but then you can use any. We use AAP charts in our unit, and for babies who are less than 35 weeks, either you can use NICE guidelines or measles chart. The AAP charts are not meant for babies who are less than 35 weeks. So these are the typical charts. You can see carefully on the x-axis, you have age of the baby in hours. On the y-axis, you can see the bilirubin levels in milligram per deciliter. And then there are some colorful lines. So all these lines, colorful lines, represents each gestational age. So these charts which you are seeing are of AAP 2022 charts. So if you can see these charts, I have mentioned that they are without, so there are no risk factors. So as I said, that the risk factors which we highlighted earlier is if the gestation age is less than 38 weeks, albumin less than 3, there is a setting for Rh hemolysis or G6PD deficiencies, or the baby is having sepsis. All these are the risk factors. If the baby has risk factors, then the chart is different. This chart is for baby who has no risk factor. So you can see for a 38-weeker baby, you have to follow the line as per this postnatal age, and if the value of the bilirubin is beyond this, then you have to start phototherapy. Similarly, this is the chart by the American Academy of Pediatrics where there is risk factor. So any of those risk factor is present, then the cutoffs are little lower, because if there is any risk factor, then the chances of toxicity bilirubin toxicity to the brain is high, so the thresholds are little lower. You tend to start phototherapy earlier. Similar charts are there for the exchange transfusion also. These are the same risk factors which we discussed, which I just showed you. Now for the preterms less than 35 weeks, either you can follow NICE charts or MEASURE charts. Here you can see for a given gestational age, you can have phototherapies or various cutoffs for exchange transfusion. So if the bilirubin levels are beyond this, you have to start phototherapy, and if it is crossing exchange transfusion, then you have to go for the exchange transfusion. These are NICE charts. So again, they are charts for each separate gestational age. Here you can see that it is for 27 weeks, but similar charts are there for each separate gestational age, right from 23 weeks till 40 weeks. So while using phototherapy, make sure that you counsel the parents upfront that baby is going to cry. While starting phototherapy, you need to continue phototherapy. You need to make sure that the baby is not getting warm or cold, because there is risk of both hypothermia and hypothermia. Try to keep the baby as close as possible to the lights. Keep on changing the position every 12 hours too early, and monitor temperature every too early. Make sure that the mother continues to breastfeed this child, and the weight and urine output is being monitored by the healthcare professional. Though phototherapy is reasonably safe, there may be some minor side effects, like if the temperature, environmental temperature is cold, then baby may become hypothermic, or sometimes there is a lot of heat produced by the older kind of phototherapies, then the baby may become hypothermic, can cause more of water loss. It affects the mother-infant bonding. Mothers are in stress, which decreases their milk output. That is one of the very common side effects which we see. And sometimes they have maculopapular reddish rash over the body, which is nothing, where nothing needs to be done with, only the reassurance is required. Similarly, sometimes the stool frequency increases, so you have to tell the parents that this is not diarrhea, it will settle down. If the jaundice is conjugated and someone has started phototherapy by mistake, then the baby's color become more like bronze, which is called as bronze baby syndrome. If the phototherapy intensity is going beyond 70 to 80 microwatt, then sometimes it may can cause oxidative stress and DNA, affect the DNA. Rarely nowadays we don't see phototherapy which can cause electrical issues, but one has to be vigilant. Now, once you have started phototherapy, you keep on monitoring the bilirubins every 12 hourly, and once the bilirubins, 2 consecutive bilirubins means they have gone below 2 mg/cent from that threshold, one can stop phototherapy. After stopping phototherapy, again one is supposed to check the bilirubin. If the baby has some risk factors as highlighted, then you need to check within 8 to 12 hours. Otherwise, you can check the rebound bilirubin beyond 18 to 24 hours, because some babies, when you stop phototherapy after 18 to 24 hours, again their bilirubins can be in that range, higher range, where again phototherapy needs to be started. Sometimes what happens that you start phototherapy and you are repeating bilirubin, the bilirubins are not coming down. So if the bilirubin is not coming down, rather they are escalating despite 4 to 6 hours of phototherapy, and they are coming very close to the exchange range where blood needs to be exchanged, then we need to go to the escalation of care. So in the escalation of care, what we do is we try to stop the interruption altogether. We shift the baby. If the baby is on feeds, we try to shift to the complete OG feeds. We stop breastfeeding. If the baby has dehydration, we give fluid therapy with the formula which you can see here. And if the baby is, there is a setting for RH incompatibility or AB incompatibility where the DCT is positive, we tend to give intravenous immunoglobulin. And if the baby crosses into the exchange range, then you don't have any option but you have to do the blood exchange, which is called as TVET, that is double volume exchange transfusion. So what is the cutoff criteria to choose at what threshold one need to do the exchange transfusion? Similarly, these are the AP charts as I highlighted earlier also. Those were for phototherapy. This is for the exchange transfusion. So you have to follow that. If the bilirubin is crossing these thresholds, one has to go for exchange. So when we do double volume exchange transfusion, there are studies to support it, and there is what kind of blood is required. We'll not go into all those details, how much blood is required, but then this is a procedure which needs a lot of expertise, and one is using those cutoffs, one exchange blood very slowly over 1 to 2 hours. The only medication which has some role in the jaundice management is IVIG, as I highlighted earlier, that this therapy is used only if there is a setting for ISO or the immune mediated hemolytic disease where the DCT is positive, and only if the values are in that close to the exchange range. The dose of IVIG is 0.5 to 1 gram per kg, and it has to be given over 1.5 to 2 hours, and this dose can be repeated in a second dose after 12 hours. Apart from that, a lot of other medicines have been tried in the treatment of neonatal jaundice, but nothing has been proved successful. So if unfortunately the baby is not recognized early, or the values, we see sometimes the babies get referred from PSCs to CSCs and CSCs to district hospital or to the tertiary care centers, and in that process the values are high, and sometimes it affects the brain, which leads to acute bilirubic encephalopathy, which in the early phase manifests as poor feeding and lethargy, and then the babies have changes from hypotonia to hypotonia. They have opisthotonous posture, seizures, and in the advanced stage they have intractable seizures, and sometimes it can lead to death. So there is a formal scoring system which is called as BIND. So if we try to see the three things like how is the cry pattern, how is the baby's overall mental state, and what is the muscle tone. Based on that, so if the score is between 1 to 3, it means it is mild variety, mild encephalopathy. If it is between 4 to 6, it is moderate bind, and if it is 7 to 9, it is severe bind. In the early bind or in the mild bind, if the exchange transfusion is done, then the damage can be prevented to a reasonable extent. But if the baby is presenting to you in stage 2 or 3, which means 4 to 6 or any score beyond 4, then despite of exchange transfusion, this baby is going to have sequelae later on. The sequelae happens in form of kernicterus, where we have chorioarthritic kind of cerebral palsies, gaze abnormalities, sensory neural hearing loss, and enamel dysplasias on the deciduous teeth. So all the babies who have any bilirubins going in the exchange range or require exchange, all these babies are followed in very closely for the neurodevelopment, and all these babies undergo apart from universal hearing screening, they also go for diagnostic BERA, where at 8 to 12 weeks to look for any sensory neural hearing loss. So once we are discharging the babies who have been reasonably normal and we discharge, so before discharge we see, because there is always a pressure to discharge even before 48 hours, 72 hours. So what we do is either we do the serum bilirubin or the transcutaneous bilirubin and try to see in this A chart. These are Bhutani's nomogram. The Dr. Vinod Bhutani is an Indian who is settled in US, and he made these charts, and which are famous by this name, Bhutani's nomogram. On the x-axis we have postnatal age, and on the y-axis we have serum bilirubin. So we need to see the bilirubin value of the baby and plot in this. So if the baby, so you can see that this chart is divided into 4 zones: low risk zone, low intermediate risk zone, high intermediate risk zone, and high risk zone. So low risk, intermediate risk zone, and high risk. Intermediate is further divided into low intermediate and high intermediate. If the value of the bilirubin at the time of discharge is falling in low risk or low intermediate risk, you can discharge this baby and call in follow-up after 24 to 48 hours. But if the baby's value is falling in high intermediate or high risk zone, this baby should not be discharged. It means this baby is at a high risk of going into pathological jaundice and needs to be kept hospitalized and with subsequent every 12-hourly serum bilirubin monitoring. So this is what we advise, that if the baby's values are less than 2 as per this, so the babies remain in the hospital. If the difference is beyond 3.5, then we discharge them and call after 24 to 48 hours for re-evaluation. Some misconceptions: sometimes mother asks that can I take yellow foods or turmeric, whether it is going to increase my baby's jaundice. So all these food items have nothing to do, because we understand the basic pathophysiology of bilirubin. So all these diets have nothing to do with that. A lot of parents ask that, because this is very cultural practices, that the newborns are shown some sunlight at home, which is completely deeply there in our culture. So remember that, as I said, that 80 to 90% of the jaundice is physiological. So whether you keep them in sunlight or whether you don't keep them in sunlight, it hardly matters. But if a baby has pathological jaundice, then sunlight, though this sunlight also contains that wavelength of 460 to 490 nanometer of the same phototherapy, but it is in very minimal amount. So this sunlight is not good enough to take care of the pathological jaundice. So usually what we advise to the parents is that if it is not pathological jaundice, if it is physiological, we are sure that it is physiological, we tell the parents that you may keep in the sunlight provided the baby doesn't become hypothermic or hyperthermic or doesn't develop any kind of burns. Color of the clothes, again, it doesn't make any difference, but sometimes what happens that if the babies had yellow colored clothes, then the light which gets reflected can cause assessment issues, visual assessment issues. So that may be an apprehension. And some parents have an apprehension that if they give goat milk or water, it will help in decreasing bilirubin. So we always advocate exclusive breastfeeding. Even in the previous talks, people were asking about if the mother is having hepatitis B, should breastfeeding be given or not. I think there cannot be any intervention like breastfeeding, which has shown all kind of advantages, whether it is short term, medium term, or long term. So all these, the breastfeeding is the answer. And of course, it is not a contagious disease. So I'll conclude by saying that it is important to differentiate physiological versus pathological. So physiological is large. There is a minor chunk of pathological, but that is important. Early identification is the key in this population. Phototherapy, if used correctly, is very effective modality and the first common modality. Exchange transfusion only if it crosses those cutoffs, and it is life-saving in severe cases, and one should give the timely treatment to prevent connectors. Thank you so much. So I think if there are questions.
Thank you, Dr. Neeraj, for such a, you covered this topic in such a simple language and yet very effective. I hope the take-home messages were all very clear, and all the misconceptions, misbeliefs, the inappropriate variation you are able to identify, because although it's very common, 90% of the babies have this, but yet we do see a lot of inappropriate variation when it comes to the management, and especially when it is about phototherapy. I think he very clearly mentioned do's and don'ts while putting the neonate under phototherapy. Excellent, Dr. Neeraj. If there are any questions, you can write here in the chat box. No questions? I think the presentation itself was so clear.
Sorry, my camera was not working, so
I
video
couldn't
was
see
not
you.
there. There is some problem in the camera, but anyways, I think the audio was pretty clear.
Yeah, yes. It was very clear, even, it helped me reviving my own knowledge. Although certain rules were very clear, the timing of onset of jaundice and the cutoffs, which we should keep in mind, and just don't, rely on the visual only method, although it is very helpful, but it can be misleading. He mentioned you about the conditions or the situations where it cannot may not be as reliable. I think there are no questions on this. With this, I would like to no questions. Can we move? You've already got the post-test link and the feedback link in the chat box. Many of you have already completed this. Please requested others also to complete this, because we would need both pre and post-test completed to issue the certificate. And I think with this we will close. Thank you, Dr. Neeraj Gupta,
Thank you
for
so
coming
much.
in, sparing time for us for this session. But this was a very, very useful session. Ranjit, can we close?
Yes, ma'am, we can close. The next session is
I think your internet connection. Next session is on thyroid disorders, right?
Yes, ma'am. Next session is on thyroid disorder on 18th of October, Saturday.
Okay, so we are left with this, two more sessions left in this series. Next is on thyroid, and the last session, 12th session, is on antimicrobial stewardship. Again, very, very important cross-cutting topic that all of us are using antimicrobials, and all of us need to keep certain principles, core interventions in mind. With this, okay, over to you, and good evening. See you next month for the next session on thyroid disorders. You will get certificate. I think Ranjit needs some time, around 10-12 days. He needs to do some cross-checking back end from attendance, pre and post test. So that takes time. So please be patient. You will definitely get, if you have done both pre and post test, you will definitely get your certificate. Don't worry about this. This will come to your email, which you use for registration for attending this webinar. And if those of you who have missed certain parts or could not attend the whole session, you can go to the YouTube channel of the NHSRC QPS channel, where you will find the recording of all the sessions, previous sessions. This session will be uploaded again. He would need some time. In another 10-12 days, he will upload this. Okay. Once again, Ranjit, you can put the post test and feedback link. We would also request all of you to provide the feedback as well. We don't get that many feedbacks as we see the numbers here who are attending. Today also there were more than 250 people attending this webinar. Okay, thank you. एक बार लिंक और डाल दो रंजीत, या मैं डाल दूं?
अब मैं डाल देता हूँ.
ओके ओके, दोनों डाल देना, फीडबैक वाला भी डाल देना.
Yes, sir. I'll do that. Thank you, ma'am. Ma'am,
पोस्टर्स का भी डाल दिया? कौन सा डाला है अभी?
अभी दोनों डाल दिया मैम.
नहीं, एक ही आया इधर. एक बार और जिन्होंने मिस किया, नहीं तो फिर they'll miss the certificate also ना. प्री टेस्ट का लिंक अब नहीं मिल पाएगा, सॉरी, बिकॉज द सेशन इज ओवर ऑलरेडी. It is actually of no use now. You can open this link, and meanwhile we can close this session. Open this link.